We are starting with another chapter of this unit, CNS, antidepressants. So what depression is? Who is going to describe what depression is? So all of you must have gone through this emotional changes. Depression is one of that. So there is mood elation, mood depression that goes on, but when it becomes a disease, when you feel sad all the time, that is, you lost interest in pleasure activities, you have all these metabolic changes, loss of appetite, etc. So that continues for 2 weeks. अगर 2 weeks से ज़्यादा चल रहा है वो, so then you call it as a major depressive disorder. ठीक है? So it could be reactive, reaction based. Yes, come in, sit in front. So याद रखो, so whenever there is, when you will diagnose it as a major depressive disorder, कब diagnose करोगे? When it continues, this depressive disorder continues for more than 2 weeks, then it is a major depressive disorder. Okay, so listen, all the objectives for this session is that you should be able to classify these antidepressants and enumerate them. You should be able to describe the mechanism of action, adverse effects, and clinical uses of antidepressants. You should be able to describe the advantages and disadvantages of SSRIs, explain what are SNRIs and atypical antidepressant and their important characteristics, and should be able to answer the case-based question related to these antidepressants. So we come to the therapy, pharmacotherapy of depression. We'll be discussing this pharmacotherapy of depression. So what are the various types of depression is? Reactive depression. ठीक है? Reaction to your day-to-day events, उसके reaction में there is a depression. For that you may not need antidepressant. ठीक है? You may not have to prescribe antidepressant. Psychotherapy alone may work. ठीक है? साइकोथेरेपी का बहुत रोल होता है उसके अंदर, रिएक्टिव डिप्रेशन के अंदर, कि इफ यू हैव फेल्ड इन एन एग्जाम और इफ देयर इज एनी लॉस, सो रिएक्शन टू दैट, so that is known as reactive depression. Now there is another, that is endogenous depression. ठीक है? So here you need to understand the pathophysiology of depression. What is endogenous depression? What happens in endogenous depression? For that you need to prescribe antidepressants. You can give antidepressant alone or you have to give electroconvulsive therapy with antidepressant. क्यों हमें antidepressant के साथ electroconvulsive therapy देनी पड़ती है? क्योंकि इलेक्ट्रोकन्वल्सिव थेरेपी का फास्टर एक्शन है, और रिमेंबर दैट एंटीडिप्रेसेंट विल वर्क इन 2 to 3 weeks. इट नॉर्मली टेक्स 2 to 3 weeks टू वर्क. एंटीडिप्रेसेंट जब भी लेना शुरू करेंगे पेशेंट, दैट विल वर्क इन 2 to 3 weeks. यू हैव टू मेक हिम अंडरस्टैंड दैट डोंट एक्सपेक्ट एन इमीडिएट इफेक्ट विद द एंटीडिप्रेसेंट, कि आपने लेना शुरू करा और उसका इफेक्ट आ गया, ऐसा नहीं होगा. 2 से 3 वीक का टाइम लगता है किसी भी एंटी डिप्रेसेंट को वर्क करने के लिए. तो ऐसा क्यों होता है, दैट यू विल अंडरस्टैंड लेटर ऑन. देन इट कैन बी अ पार्ट ऑफ मेनिक डिप्रेसिव साइकोसिस. ठीक है? बाइपोलर डिसऑर्डर जिसे हम कहते हैं, उसका भी एक पार्ट हो सकता है जिसमें मेनिया और डिप्रेशन रन करता है साइकिल में, कि कभी तो उसे मेनिया एपिसोड हो रहा है और कभी उसे डिप्रेसिव एपिसोड हो रहा है. ठीक है? तो इट कुड बी अ पार्ट ऑफ दैट. तो उसके अंदर दोनों दवाई चलती हैं, मेनिया की भी दवाई चलेगी और डिप्रेशन की भी दवाई चलेगी. ठीक है? यू हैव टू स्टेबलाइज द मूड. सो दीज आर द टाइप ऑफ मूड डिसऑर्डर. Understand the pathophysiology in these mood disorders. So in the limbic system, if there is increase in dopaminergic activity, so that is happening in schizophrenia. वहां पे आपको कुछ ऐसी दवाई देनी पड़ेगी जहां पे आप डोपामिनर्जिक की एक्टिविटी को कम करोगे, ठीक है। दैट इज अ साइकोसिस। तो हम क्या देते हैं टिपिकली? D2 ब्लॉकर्स, ठीक है। हम डोपामीन की ब्लॉक करते हैं वहां पे, वो साइजोफ्रीनिया को ट्रीट करने के लिए, क्योंकि वहां पे इंक्रीज हो रही है लिम्बिक सिस्टम में डोपामिन की एक्टिविटी। यहां पे क्या हो रहा है? देयर इज डिप्लीशन ऑफ मोनोअमिनर्जिक न्यूरोट्रांसमीटर एक्टिविटी, दैट इज नॉरएपिनेफ्रिन एंड सेरोटोनिन, ठीक है। यहां पे नॉरएपिनेफ्रिन और सेरोटोनिन को बढ़ाने के लिए हम दवाई देंगे कि जो चीजें नॉरएपिनेफ्रिन और सेरोटोनिन की एक्टिविटी को बढ़ा दे एट द सिनेप्टिक लेवल, वो ऐसी दवाएं हम देंगे डिप्रेशन के अंदर। और इंक्रीज हो रहा है नॉरएपिनेफ्रिन एक्टिविटी दैट अकर्स इन मेनिया, दैट इज अपोजिट टू व्हाट हैपेंस इन डिप्रेशन। वहां पे डिप्लीशन हो रहा है नॉरएपिनेफ्रिन की एक्टिविटी, यहां पे इंक्रीज हो रही है नॉरएपिनेफ्रिन की एक्टिविटी। तो हमारे पास ऐसी कौन सी ड्रग्स हैं जो ये काम करेंगी? दीज आर एंटी डिप्रेसेंट्स, सो दे आर क्लासिफाइड एज मोनोअमीन ऑक्सीडेज इनहिबिटर्स। मोनोअमीन ऑक्सीडेज वो एंजाइम है जो कि इन मोनोअमीन्स को मेटाबोलाइज करती है। तो अगर आप उसको इनहिबिट करोगे, सो दैट विल इंक्रीज द मोनोअमीनर्जिक एक्टिविटी, ठीक है। तो मोनोअमीन ऑक्सीडेज A inhibitors you are giving specifically. There are two types of monoamine oxidase, A and B. दो तरह के होते हैं. So A is metabolizing these monoamines, whether it is serotonin, whether it is norepinephrine or a dopamine. ठीक है. Monoamine B is more selective for metabolizing the dopaminergic activity. कहाँ यूज होते हैं मोनोअमीन बी इनहिबिटर्स? मोनोअमीन बी इनहिबिटर्स कहाँ पे यूज हो रहे हैं? पार्किंसंस डिजीज के अंदर। वहां पे आपको क्या करना है? डोपामीन की एक्टिविटी को बढ़ाना है कि कम करना है? बढ़ाना है। साइजोफ्रीनिया में कम करते हो, पार्किंसंस डिजीज में बढ़ा रहे हो आप डोपामीन की एक्टिविटी को, ठीक है। तो वहां मोनोअमीन ऑक्सीडेज बी इनहिबिटर्स सेलिजिलिन इज यूज इन पार्किंसोनिज्म। हियर मोनोअमीन ऑक्सीडेज ए इनहिबिटर्स आर यूज मेनली, दैट इज मोक्लोबिमाइड। देन यू हैव दिस ट्राइसाइक्लिक एंटीडिप्रेसेंट्स। ट्राइसाइक्लिक एंटीडिप्रेसेंट्स की बात करें तो दे आर द फर्स्ट जनरेशन एंटीडिप्रेसेंट्स। दे आर इफेक्टिव ग्रुप ऑफ एंटीडिप्रेसेंट। यहाँ पे बहुत इफेक्टिव ग्रुप है, लेकिन इनके साथ ऐसे साइड इफेक्ट्स हैं कि विच इज नॉट टॉलरेबल बाय मोस्ट ऑफ द पेशेंट्स बिकॉज इट इज नॉट सिलेक्टिव इन एक्शन, इट इज इनहिबिटिंग द रीअपटेक। ये एक कॉमन इनका मैकेनिज्म है। व्हेन एंटीडिप्रेसेंट की बात करें तो ये रीअपटेक इनहिबिट करते हैं सेरोटोनिन या नॉरएपिनेफ्रिन का। So they are known as serotonin or norepinephrine reuptake inhibitors. ठीक है, तो मैकेनिज्म पूछे, so what is the typical mechanism? Is the reuptake inhibition by acting on its specific transporter, serotonin transporter or norepinephrine transporter, जो कि reuptake कर रहे हैं उसको inhibit करके they work. But because of the non-selective action, they have certain side effects which are not there with the selective SSRIs or SNRIs. ठीक है, वो भी क्या कर रहे हैं? Selective serotonin reuptake inhibitors हैं और selective serotonin and norepinephrine reuptake inhibitors. So tricyclic antidepressants में you have this inhibitors like imipramine, amitriptyline, trimipramine, doxepine, diazepam, clomipramine, and predominantly norepinephrine reuptake inhibitors, diazepam, nortriptyline, amoxapine and reboxetine. ठीक है, amoxapine का एक और पर्टिकुलर एक्शन होता है कि ये D2 ब्लॉक भी करता है, तो इसको हम साइकोटिक डिसऑर्डर में भी दे सकते हैं, which have a depression associated with psychotic disorder. You have a drug like amoxapine which is given. Then selective serotonin reuptake inhibitors, इसका बहुत इंपॉर्टेंट ग्रुप है जब हम एंटीडिप्रेसेंट की बात करते हैं। तो अगेन एंड अगेन विल बी आस्किंग SSRIs because these are the commonly prescribed drug. So you should know the names of these drugs like fluoxetine, fluvoxamine, sertraline, citalopram. These are the first choice of drugs which has to be started as an antidepressant in most of the patients. Then atypical SNRIs you have, that is venlafaxine, duloxetine, then another newer drugs milnacipran. This is the SNRIs. Okay? They are the first choice of drug in case of severe depression. क्योंकि इसका action compared to the other antidepressant is more faster in action as compared to the other, and they are the drug of choice in case of severe depression. Then you have these atypical antidepressants. They are usually given in case of resistant type of depression. They work in a different mechanism compared to the typical antidepressants, which work by inhibiting the reuptake mechanism. ठीक है, तो दे आर द ट्रेज़ाडोन, मियांसिरीन, मिर्टाज़ापिन, बुप्रोपियोन, टाइनाप्टेन, अमीनाप्टेन, अटोमोज़ैटिन. Now first we come to monoamine oxidase A inhibitors. So again they are of two types, A and B. तो पहले कौन सी आई थी drugs? They are non-selective which are acting on A and B both. ठीक है, ट्रेनाइलसाइप्रोपीन, फिनालजीन जो ड्रग्स थी, they were acting on both, inhibiting A and B, but they are no longer used because of the certain side effects. And now what is the drug which is used in this group is MAO-A inhibitor, जो A enzyme को inhibit कर रही है, जो कि है moclobemide chlorgyline. ये short acting है, reversible in action, so it is preferred to be given in elderly patients with heart disease. And it is also a drug to be given in mild to moderate type of depression and social phobia. इसमें वो फूड और ड्रग इंटरेक्शंस नहीं हैं जो कि पहले वाली ड्रग्स में. So this is the advantage with moclobemide group, and it can be used as an alternative to tricyclic antidepressants. तो क्या इसके रिएक्शन होते थे? Now monoamine oxidase A inhibitor, when it is inhibiting both A and B, which is present in the intestine, liver, peripheral nerve endings, तो ये क्या करते थे? When the cheese like foods which containing tyramine, so ये tyramine contain करता था. Tyramine का क्या रोल है? Tyramine will causes the indirectly the release of the sympathetic neurotransmitter norepinephrine. Tyramine क्या कर रहा है? It increases the release of norepinephrine from the adrenergic neurons. तो उससे क्या होता है? टायरामीन अगर मेटाबोलाइज नहीं होगा, टायरामीन मेटाबोलाइज हो रहा है मोनोअमीन ऑक्सीडेज ए एंड बी एंजाइम से, तो अगर वो इरिवर्सिबली इनहिबिट हो गए, ठीक है, दोनों ही एंजाइम आपके काम नहीं कर रहे हैं, तो टायरामीन बहुत ज़्यादा इंक्रीज हो जाएगा ब्लड में और नॉरएपिनेफ्रिन का लेवल बहुत इंक्रीज हो गया, तो उससे क्या होगा? हाइपरटेंसिव क्राइसिस होगी. ठीक है, सो ये ड्रॉबैक थे. तो इसको बहुत ध्यान रखना पड़ता था कि अल्कोहल और एनी फूड विच कंटेन्स टायरामीन मे कैन कॉज हाइपरटेंसिव क्राइसिस इन दीज पेशेंट्स. So this is not there much with this moclobemide. So what is the main side effect? But it is increasing the norepinephrine and serotonin level, so it may have nausea, dizziness, headache, insomnia, excitement, and you have to be careful about the liver damage. So on long term, if it is given, it may cause liver damage too. Another thing you have to take care is you should not give this monoamine oxidase inhibitors with any other drugs which increases the serotonin level. ठीक है, तो whenever अगर आप स्विच ओवर कर रहे हो कि जिसने मोनोअमीन ऑक्सीडेज इनहिबिटर आपने दिए पेशेंट को, तो उसके एक वीक तक यू शुड नॉट प्रिस्क्राइब SSRIs. ठीक है, अगर SSRIs इमीडिएटली आपने प्रिस्क्राइब करना स्टार्ट कर दिया वो बंद करके, तो उसमें अभी वो इनहिबिटेड ही रहेंगे. उसको एक वीक तक चाहिए कि मोनोअमीन ऑक्सीडेज एंजाइम्स रिवाइव कर सकें. ठीक है, बट इट इज मॉक्लोबेमाइड क्या है? इसका बेनिफिशियल इफेक्ट, इट इज अ शॉर्ट एक्टिंग ड्रग. But if you are giving any other monoamine oxidase inhibitor, you have to take at least 1 week gap to prescribe SSRIs in them. Otherwise, serotonin syndrome, serotonin का level बहुत ज़्यादा हो गया तो it may cause these symptoms like fever, rigidity, tremors and all this. This is known as serotonin syndrome. Like pethidine like drugs and all, they also increase the serotonin level and they may also interact with it and may cause this serotonin syndrome. ठीक है, तो इसके साथ आपको इस चीज़ का ध्यान रखना है when we talk about the drug interaction. Okay, so we have this question. All the following can cause serotonin syndrome when combined with monoamine oxidase inhibitor, except, okay, roll number 20. बताओ, all the following can cause serotonin syndrome when combined with monoamine oxidase inhibitors, except tricyclic antidepressant है, selective serotonin reuptake inhibitors, carbamazepine और tyramine containing food. Tyramine containing food serotonin syndrome कर रहा है क्या? दो पहले वाले क्लियर हैं. अब कार्बामेजेपिन की बात हुई और टायरामीन कंटेनिंग फूड की बात है. टायरामीन कंटेनिंग फूड, हैव यू अंडरस्टूड व्हाट दे आर डूइंग? इज इट कॉजिंग सेरोटोनिन सिंड्रोम? So the answer is tyramine containing food. ये hypertensive crisis कर रहे हैं. They are not causing the serotonin syndrome. They are not increasing the serotonin. They are increasing norepinephrine. They are not increasing serotonin. So they are not causing serotonin syndrome. But carbamazepine can cause this serotonin syndrome because it also increases the serotonin level. So you have to be careful with carbamazepine, which is an anti-epileptic drug. It may also cause serotonin syndrome. Another thing is, classify these antidepressants and enumerate them. Roll number 3. कैसे हमने क्लासिफाई करें एंटीडिप्रेसेंट? बिकॉज ऑफ द ऑटो रिसेप्टर्स. ठीक है, ऑटो रिसेप्टर्स जो अल्फा रिसेप्टर्स प्रेजेंट हैं एड्रिनर्जिक न्यूरॉन्स पे या सेरोटोनर्जिक न्यूरॉन्स पे, 5-HT1 रिसेप्टर्स आर प्रेजेंट. नाउ दे कॉजेज फीडबैक इनहिबिशन. सो अगर फीडबैक इनहिबिशन है, सो दिस विल कॉज डिक्रीज इन रिलीज ऑफ नॉरएपिनेफ्रिन एंड सेरोटोनिन. कुछ टाइम में 2 to 3 weeks there is desensitization of these receptors will occur. So this adaptive changes which occurs in the presynaptic and the postsynaptic receptors, that is mainly important for antidepressant action. Okay, that's why it takes 2 to 3 weeks time. Now another important thing is there is depletion of brain derived neurotropic factor in depression. Brain derived neurotropic factor is the one which is being depleted, which has been seen to be depleted in the depressive patients, and this monoaminergic transmission, when it is increased, it also increase the brain derived neurotropic factor, which is important in neuronal plasticity. ठीक है, so another pathophysiology in a depression which is being given is not only monoaminergic transmission but this brain derived neurotropic factor, this is also been found to be depleted in the patients of depression. और ये monoaminergic transmission जो ड्रग्स बढ़ा रहे हैं, ये बेसिकली क्या कर रहे हैं, ये इंक्रीज कर रहे हैं ब्रेन ड्राइव न्यूरोट्रॉपिक फैक्टर को भी. Now साइड इफेक्ट्स की बात करें, क्या क्या साइड इफेक्ट्स है इसके साथ? देयर आर M1 एंटीकोलिनर्जिक साइड इफेक्ट्स, दैट इज ड्राई माउथ, ब्लरिंग ऑफ विजन, यूरिनरी रिटेंशन, कॉन्स्टिपेशन. तो ये सारे एंटीकोलिनर्जिक साइड इफेक्ट्स हैं ट्राइसाइक्लिक एंटीडिप्रेसेंट्स के साथ. हिस्टामिन की वजह से सेडेशन एंड वेट गेन. अल्फा ब्लॉकिंग की वजह से पोस्चरल हाइपोटेंशन, टेकिकार्डिया कैन अकर. Direct membrane effect is because of this sodium channels they block directly. It may cause arrhythmia. It may reduce the seizure threshold too. Then there is a sexual distress. Switchover can occur in patients of bipolar disorder, may go for mania if you are continuing with antidepressant alone. Sweating and fine tremors can occur because of increased serotonergic activity. Acute poisoning can occur. कोई depressive patients may take lot of pills of antidepressants, so they are prone to go for acute poisoning, which may have all these symptoms: anticholinergic, direct membrane effect, lower seizure threshold, and alpha blocking activity or H1 blocking activity. तो आप कैसे रिवाइव करोगे उस पेशेंट को? पॉइजनिंग में है, क्या दोगे? IV sodium bicarbonate. For ventricular arrhythmias, you will give lignocaine. For convulsions, you will give diazepam. For hypotension, you will give IV fluids. ठीक है? And for anticholinergic activity, you can give physostigmine. So you have to do the symptomatic treatment of the patient. Now, you have also to be careful when you're administering other drugs, because interactions can be there. कोई और sympathetic drug दे रहे हो या कोई और serotonergic drugs दे रहे हो. Again, you have to be careful with this also. Tricyclic antidepressants, it may potentiate the directly acting sympathetic drugs, and also indirectly acting sympathomimetic drugs. Action may be hurdled or blocked by these drugs. इनडायरेक्टली एक्टिंग कौन सी होती हैं? जो डायरेक्टली रिसेप्टर पे काम ना करके इंक्रीज कर रही हैं इनडायरेक्टली रिलीज ऑफ नॉरएपिनेफ्रिन और सेरोटोनिन. ठीक है, या सिंपैथोमिमेटिक की बात कर रहे हैं तो नॉरएपिनेफ्रिन इज इंक्रीज. ठीक है, उसका एक्शन कैसे डिले करेगा? इट मे हर्डल इट बाय दिस रीअपटेक इनहिबिशन एक्टिविटी. इट मे हर्डल द रिलीज ऑल्सो. So it will block the indirectly acting sympathomimetic agents, potentiate the drugs which is causing the CNS depression, including alcohol and antihistaminics, phenytoin, phenylbutazone, aspirin, and chlorpromazine. They can displace the tricyclic antidepressants from the protein binding and can lead to poisoning of tricyclic antidepressants. Phenobarbital may completely inhibits as well as induces the metabolism of imipramine. SSRIs against serotonin syndrome. Then it also delays the gastric emptying, so it may affect the absorption of the many of the drugs, but digoxin and tetracycline may be more completely absorbed. And monoamine oxidase A inhibitors can cause dangerous hypertensive crisis when it is given with these drugs. So these are the drug interactions. So coming to this question, so role number 25. A person on tricyclic antidepressant presents with blurring of vision and dry mouth. The adverse effects result due to blockage of. So this is M3 receptor. ठीक है, muscarinic M3 receptor की वजह से ये एक्शन हुआ है. Now GABA A receptor पे भी इसका इफेक्ट होता है. It is not that the GABA A receptors is not being affected. It is also affected, which is the cause for lowering the seizure threshold in these patients. It inhibits the GABA activity, increasing the norepinephrine activity. उससे क्या हो रहा है? It lowers the seizure threshold. Sit down. लेकिन अब हम यूज कर रहे हैं सिलेक्टिव सेरोटोनिन रीअपटेक इनहिबिटर्स, एंड इट इज वेरी इंपॉर्टेंट. अगेन एंड अगेन द क्वेश्चन इज आस्क्ड, सो व्हाट वाज द लिमिटेशन विद ट्राइसाइक्लिक, एंड ये अभी हम इसे कहते हैं सेकंड जनरेशन एंटी डिप्रेसेंट्स. तो ऐसी क्या एडवांटेजेस हैं और ट्राइसाइक्लिक एंटी डिप्रेसेंट में क्या लिमिटेशंस थी? These side effects were there, they were frequent, low safety margin, lag time is there, significant number of patients respond incompletely, and some do not respond with tricyclic antidepressants. So we have this SSRIs. So they are these advantages: no anticholinergic side effects, no hypotension, no sedation, do not precipitate convulsions, do not cause cardiac arrhythmia, orally effective drug. These are all the advantages of SSRIs. क्योंकि इसकी इट इज ओनली इनहिबिटिंग द रीअपटेक मैकेनिज्म, ये और बाकी रिसेप्टर्स पे इसका एक्शन नहीं है, सो इट इज सेफ टू बी गिवन. Now, who will describe the mechanism of action and adverse effect of tricyclic antidepressant? So, rule number 30. Mechanism of action and adverse effect क्या हमने अभी तक देखा? So, inhibiting the reuptake mechanism, increasing the monoaminergic turnover by there is desensitization of presynaptic and postsynaptic. You have to completely explain. ठीक है, इसीलिए इसका एंटीडिप्रेसेंट एक्शन आता है. And that's why there is a lag time of 2 to 3 weeks. Now, what are the adverse effects with tricyclic antidepressants? Direct membrane effect, cheese reaction was seen with monoamine oxidase inhibitors. Direct membrane effect, sexual distress, switchovers, acute poisoning, tremors. So these are all the adverse effects are seen with tricyclic antidepressants. So these are all the SSRIs: depoxetine, citalopram, sertraline, fluoxetine. Fluoxetine is the longest acting antidepressant and fluvoxamine is the shortest acting among this SSRIs. Now, what are the immediate side effects with SSRIs? Nausea. क्यों होगा? serotonin ले लिया ना chapter. Who will tell? Nausea and diarrhea are the most important adverse effect with SSRIs. लेकिन आप कुछ टाइम तक देते हो पेशेंट को, they get tolerated to these adverse effects. क्यों होते हैं ये एडवर्स इफेक्ट्स? नॉजिया, डायरिया. कौन बताएगा? सेरोटोनिन पढ़ा है? 5-HT3 receptor, 5-HT4 receptor, if you'll remember. Now they are responsible for causing nausea, diarrhea. Because the action over there, it may result in nausea and diarrhea. Anxiety may occur, drowsiness, insomnia. It may cause sexual dysfunction. Drug interactions can be there. If you're giving with other antidepressants, again serotonin syndrome tendency can be there with this. So most common adverse effect is nausea and diarrhea with this. Now this may usually disappear within 4 weeks because patient get tolerated to it, and side effects are manageable compared to your first generation antidepressants. Sexual side effect is common, and serotonin syndrome again is a complication which you have to be careful while prescribing SSRIs too. So this is the drug which is used for not only depression but prophylaxis of recurrent depression also, and it is the first choice of drug in other kind of neurotic diseases like obsessive compulsive disorders हो गया, social phobia, eating disorder, premenstrual dysphoric disorder, post-traumatic stress disorder, या anxiety disorder, body dysmorphic disorder, compulsive buying, kleptomania, premature ejaculation. Then in this also they can be used as a first choice of drug. अब कौन बताएगा न्यूरोसिस और साइकोसिस में क्या फर्क होता है? साइकोसिस और न्यूरोसिस में क्या फर्क होता है? Psychosis is patient jab lost their insight. He doesn't know that is a more severe form. He doesn't know he's suffering from some disease. When there is insight is left behind, that is neurotic, which includes milder disorders. ठीक है, जैसे obsessive compulsive disorder हो गया, kleptomania हो गया, anxiety हो गई. So these are coming under neurosis where patient has the insight. Partial insight is there in the patient and patient try to treat herself or himself. ठीक है, बट साइजोफ्रीनिया हो गया या मेजर डिप्रेसिव डिसऑर्डर हो गया या मेनिया हो गया, दे लॉस्ट ऑल द इंसाइट, they doesn't know they are suffering from some disorder. So that is the main difference in psychosis and neurosis. So this how SNRIs are different. SNRIs is selectively inhibiting both serotonin and norepinephrine. The side effects or uses are almost similar to SSRIs. You have venlafaxine and duloxetine in this group. ठीक है, लेकिन एक चीज जो एक साइड इफेक्ट ज्यादा होगा इसके अंदर वो क्या हो सकता है, दे आर मोर फास्टर कंपेयर टू द अदर एंटी डिप्रेसेंट्स. अब इसमें नॉरएपिनेफ्रिन जो इंक्रीज कर रहा है, सो इट मे कॉज hypertension. You have to be careful if you are giving to a patient which is already hypertensive. SNRIs may precipitate the hypertension episodes. Now there are some other uses to this drugs. Duloxetine is also used in fibromyalgia and urinary incontinence. ठीक है, वहाँ पे भी duloxetine can be used. So these are the other roles. Then other is neuropathic pain. So these are the other uses of SNRIs. यहाँ तो यूज कर ही रहे हैं, इससे अलावा कहाँ यूज कर रहे हैं हम इनको, urinary incontinence and neuropathic pain. So roll number 45. So can you explain the advantages and disadvantages of SSRIs? Advantages क्या हैं SSRIs के? Yes, no sedation. So these side effects anticholinergic और histaminergic, direct membrane effect या alpha blocking side effects नहीं है इसके साथ. ठीक है, बट क्या है फिर? So these are the side effects they are having. So this again, both of them, whenever you are giving any antidepressant, you have to be careful for the drug interaction with it. Now what are the other advantages with SSRIs which you have missed? Multiple neurotic disorders, again it is the first choice of drug. ठीक है, जो ये मल्टीपल न्यूरोटिक डिसऑर्डर्स हैं जिसकी बात हमने करी थी, अगेन इट इज अ फर्स्ट चॉइस ऑफ ड्रग इन दिस. So roll number 50 again. There is a question, a patient of depression stabilized on SSRIs. This group presents with withdrawal symptom when stopped. Which drug has minimum risk of drug discontinuation symptoms? In this, अगर एकदम से आपने ड्रग डिसकंटिन्यू कर दी तो देयर कुड बी सम ड्रग डिसकंटिन्यूएशन सिंड्रोम सिम्टम्स. ठीक है, नाउ व्हाट drug can cause drug discontinuation, which has a minimum risk of drug discontinuation symptoms? Fluvoxamine. Why? Fluvoxamine is the shortest acting. बताओ, फ्लोवोक्सामीन शॉर्टेस्ट एक्टिंग है या लॉन्गेस्ट एक्टिंग है? शॉर्टेस्ट एक्टिंग. Yes, so fluvoxamine is the shortest acting, and this drug discontinuation symptoms cannot be there with fluvoxamine or fluoxetine, जो longest acting है. शॉर्ट एक्टिंग के साथ नहीं होगा या लॉन्ग एक्टिंग के साथ नहीं होगा? किसमें रिसेप्टर्स का डिसेंसिटाइजेशन या डाउन रेगुलेशन या सेंसिटाइजेशन ज्यादा होता है, लॉन्ग एक्टिंग ड्रग्स या शॉर्ट एक्टिंग ड्रग्स? लॉन्ग एक्टिंग ड्रग्स, नॉट द शॉर्टर वन. शॉर्टर वंस का ज्यादा एक्शन नहीं रहता. शॉर्टर वन के कंपेयर में लॉन्गर एक्टिंग ड्रग्स हैव अ मोर एक्शन. ठीक है, Now describe the advantages and disadvantages. We have already discussed. Atypical antidepressant पे आते हैं. Atypical antidepressant you have trazodone, mianserine, mirtazapine, bupropion, tynaptin, aminaptin, atorvastatin. इसके अलावा भी there are certain other drugs which have come up recently. But let's understand क्या इनका mechanism है which is different from the typical antidepressants. Trazodone, it has a weak 5-HT blocking action. ठीक है, 5-HT blocking action is there. It also has alpha blocking action and other receptor blocking action, but it is a 5-HT blocking effect. ठीक है, 5-HT blocking effect. Again, it also blocks the 5-HT reuptake. So these are the two mechanisms it is having. So it is not increasing the serotonergic activity at 5-HT, but it is blocking the serotonergic activity at the 5-HT receptor. So this is atypical from the typical antidepressant. But it has shown to have an antidepressant action, though it may have the side effects like postural hypotension, priapism, tachycardia. These side effects are there, sedation, these side effects are there with this drug also, trazodone. Nefazodone की बात करें, that also have a 5-HT blocking effect. Mianserine, it increases the norepinephrine release. ठीक है, ये रीअपटेक इनहिबिट नहीं कर रहा है, बट इसका क्या इफेक्ट है, दे आर एक्टिंग ऑन द ऑटो रिसेप्टर्स. ठीक है, दे हैव एन अल्फा ब्लॉकिंग इफेक्ट एट द ऑटो रिसेप्टर. अल्फा 2 रिसेप्टर को ब्लॉक कर देगा, जिससे क्या हो रहा है कि नॉरएपिनेफ्रिन की रिलीज इंक्रीज हो रही है. अल्फा 2 ब्लॉक करने से इंक्रीज रिलीज होगी कि अल्फा 2 अगोनिज्म से होगी रिलीज इंक्रीज. दिस इज क्लियर. अल्फा 2 ब्लॉक करने की वजह से इंक्रीज हो रहा है, और अल्फा 2 अगोनिज्म जो करेगा वो करेगा फीडबैक इनहिबिशन. ठीक है, तो अल्फा 2 ब्लॉक कर रहा है ये एड्रिनर्जिक रिसेप्टर्स, एंड इट इज इंक्रीजिंग द रिलीज ऑफ नॉरएपिनेफ्रिन. ठीक है, तो इसका एक्शन क्या है, बाय एक्टिंग ऑन द ऑटो रिसेप्टर्स, बाय ब्लॉकिंग द ऑटो रिसेप्टर. Mirtazapine not only blocking the autoreceptor but also the heteroreceptors. ठीक है, heteroreceptors, that is serotonergic neurons पे भी it is blocking these heteroreceptors which is involved in feedback inhibition. So it is increasing both the norepinephrine and serotonin release. ठीक है, mirtazapine increasing both the serotonin and norepinephrine release by having an action on the autoreceptor and heteroreceptor. इसका एक और चीज है, it is noradrenergic, serotonergic, selective antidepressant. क्योंकि ये 5-HT1 पे तो इसका agonistic है इफेक्ट, but it is blocking the 5-HT3 and 5-HT2 receptors. ठीक है, तो कुछ सेरोटोनर्जिक रिसेप्टर्स पे इट इज ब्लॉकिंग एंड कुछ सेरोटोनर्जिक रिसेप्टर पे इसका अगोनिस्टिक एक्शन है. सो दिस सिलेक्टिव सेरोटोनर्जिक एक्शन जो है, इसकी वजह से इसे हम कहते हैं नॉरएपिनेफ्रिन सेरोटोनिन सिलेक्टिव एंटीडिप्रेसेंट. अगर ये पूछा जाए तो कौन सी ड्रग है वो है मिर्टाज़ेपिन. बिप्रोपियोन क्या कर रहा है, बिप्रोपियोन इज ऑल्सो इनहिबिटिंग द रीअपटेक ऑफ डोपामीन. डोपामीन को भी इंक्रीज कर रहा है, तो इसे हम कहाँ देंगे, स्मोकिंग सेसेशन में. बुप्रोपियोन इज द ड्रग विच इज यूज्ड इन स्मोकिंग सेसेशन. अनदर ड्रग यू हैव टाइनैप्टिन और अमीनैप्टिन. ये तो इनका जस्ट अपोजिट एक्शन है विच इज द टिपिकल एंटी डिप्रेसेंट हैव. क्या एक्शन है, इट इज नॉट इनहिबिटिंग द रीअपटेक बट it is increasing the reuptake. It is not inhibiting the reuptake, but it is increasing the reuptake. So that is how it is different. But in some types of resistant depression, this tynaptin and aminaptin may work. So you don't have a clear-cut mechanism of these atypical antidepressants, why they are working when the mechanism is being explained that by increasing the turnover by this mechanism actually the antidepressant works. But there are certain antidepressants like tynaptin and aminaptin which works just opposite to the typical antidepressants. They are rather increasing the reuptake of the serotonin rather than inhibiting the reuptake. Then atorvastatin, it is a selective norepinephrine reuptake inhibitor and it is used in attention deficit hyperactivity disorder. ठीक है, तो इसका important role है attention deficit hyperactivity disorder. There are other two antidepressants, that is esketamine, which is NMDA receptor antagonist. Now this esketamine is also given by intranasal spray. This is again being used in certain type of depression. Then another drug is brexanolone, which is used in postpartum depression. This brexanolone is a neurosteroid. Now this is given as an IV drug in postpartum depression. They all are coming in atypical antidepressants. Their work is different from the typical antidepressants. Then you have vortioxetine. Okay, another drug, vortioxetine. Now this is again being used in case of severe depression where the other antidepressant does not work. So you need not have to know about these drugs. These are the recently come up, but if you are interested, you can write down these drugs in atypical antidepressant. Otherwise, these drugs are there which you need to know as given in your books. These are the drugs which can be used in atypical antidepressants. So now coming to the uses. Now we just summarize all the uses of antidepressants. What are the uses of antidepressants? You can remember this mnemonic: D for depression, E for enuresis. Okay? Enuresis, nocturnal enuresis. Again, this tricyclic antidepressants can be used, and desmopressin is the drug of choice in nocturnal enuresis. P for phobia. R for recurrent panic attacks. S for smoking cessation. Another S for stress disorder. I for impulse disorder, O for obsessive compulsive disorder, and N for neurotic disorders. So this is DEPRESSION. And your first choice of drug is second generation antidepressant, and you have to continue to be given for 6 to 12 months these antidepressants to prevent the recurrence of depression. Now there is a role of electroconvulsive therapy which is to be given in severe cases. Okay? Because there are suicidal chances. To prevent that suicidal chances, immediate therapy you need to be given in case of severe depression, and for that you need electroconvulsive therapy. Then another thing is pruritus. Pruritus, again, antidepressants are used like doxepin. Elderly and heart disease patients, you have the drug like moclobemide which can be given. Premature ejaculation, again you have a drug like SSRIs which can be given in premature ejaculation. So these are the other uses, and then you have the other uses of antidepressants like fibromyalgia, neuropathic pain, and incontinence where SNRIs can be given. Okay, smoking cessation and all we have already talked about. So all these neurotic and psychotic disorder, you are giving these antidepressants. Bipolar depression or in major depressive disorder, you are using SSRIs is the first choice of drug in preventing any or as a prophylaxis of recurrent depression. So let's see this question. A 36-year-old woman present with symptoms of major depression that are unrelated to general medical condition, bereavement or substance abuse. She is not currently taking any prescription or over-the-counter medication. Now the drug treatment to be initiated with paroxetine in your information to the patient. You would tell her that, this is clear question, but just for understanding I have kept this question. You have to tell her that it is preferable that she does not take the drug in the evening because it causes insomnia. These drugs can cause insomnia. So you say it is preferable that she does not take the drug in the evening. Muscle cramps and twitches can sometimes occur. She should tell you if she anticipates using other prescription drugs. The antidepressant effect of paroxetine may take 2 weeks or more to become effective. So all of the above is the answer. So this another question. A 34-year-old patient who was prescribed citalopram for depression and has decided he wants to stop taking the drug. When questioned, he said it was affecting his sexual performance, and you ascertain that he is also trying to overcome his dependency on tobacco product. If you decide to reinstitute drug therapy in this patient, the best choice would be bupropion. Okay, the best choice is bupropion. So there is a balance which occurs in this, that is serotonin, opioids or cannabinoids. They are causing the inhibition, and dopamine, norepinephrine, oxytocin and all. So these are the excitatory. So there have to be a balance for this normal functional activity. Now another case-based question related to it. So there is a businessman aged 35 years suffering loss and his employees left. He became very depressed and stopped taking interest in the business. Gradually he stopped going out and withdraw socially. Now he felt guilty, worthless and tired all the time, lost interest in pleasure and sex, stopped eating properly and has disturbed sleep. When he showed no signs of recovery, even after 3 months, the family members consulted a doctor who diagnosed him to be a case of major depression and prescribed tablets sertraline 50 milligram twice a day and a multivitamin. So what is sertraline is? SSRIs. The family members brought him back after 1 week and complained that there was no improvement, and on questioning the patient revealed that he felt more restless, nausea, pain in upper abdomen, headache and no desire to eat. Now what could be the reason for no improvement in the depressive symptoms? Roll number 120. Yes. So what could be the reason for no improvement in the depressive symptom? क्यों उसे कोई रिलीफ नहीं मिला? दिस इज द फर्स्ट चॉइस ऑफ ड्रग टू बी गिवन एज एन एंटीडिप्रेसेंट. तो बट क्यों उसे इफेक्ट नहीं आया? क्या रीजन हो सकता है? इफ एनीबडी वांट्स टू आंसर कैन रेज योर हैंड. क्यों नहीं आया होगा उसे इफेक्ट? You all of you know the answer. Just think about it. Why the patient is not recovered? This is 1 week history. and lag time of 2 to 3 weeks at least needed for antidepressant effect to come. So you have to explain to the patient that to have to wait for 2 to 3 weeks for the effect to come. The other question is, does the medication need to be changed or is the drug inappropriate? No, the drug is not inappropriate, or the dose, does the medication need to be changed? You need not have to change the medication so soon. The dose increase or decrease, you don't have to do anything with the dose. This is not related to the dose. Should another drug be added at this stage? Again, the answer is no. You have to explain to the patient that he has to come only after 3 weeks, 3 to 4 weeks. 1 month का wait उसे चाहिए, and then only he has to see that whether his symptoms are relieved or not. ठीक है? So that is very important, because this is the common problem which is coming whenever the antidepressants are prescribed and it is not taken regularly. Tell the patient to take it regularly. There is a problem of compliance with the antidepressant. They don't take it because the immediate effect is not seen. So there is no immediate effect with the antidepressants. It takes around 3 to 4 weeks for its effect to come. And for any other side effects and all, again it takes 3 to 4 weeks for the tolerance effect to come. तो उससे पहले side effects आएंगे. So you have to tell the patient कि ये side effects आएंगे. ठीक है? And symptomatically you have to give certain other drugs to relieve those side effects if they are bothering him or her much. ठीक है? तो जब भी आप antidepressants prescribe कर रहे हो तो you have to take care of these things. कि पहला महीना बुरा रहेगा because the side effects will come and the antidepressant effect will not come. And then there is a tolerance to these side effects, and then the antidepressant effect will remain.